The talk is about adult sleep disorders and why should we treat them. Okay, so I'm going to start off just by talking a little bit about what normal sleep is before we talk about what is abnormal or physiologically inappropriate sleep. This is a summary of what normal sleep is. This is a way of condensing sleep architecture, and instead of using a lot of technical terms, your y-axis talks about wake, which is the very top line, REM, which is underlined in red and shown in red on the hypnogram, and then 1, 2, 3, and 4, which are different stages of sleep. One of the things I often have people ask me when they come to the office about is I'm not getting enough slow wave sleep, but often they'll say I'm not getting enough deep sleep, and I'm tired and I'm not rested when I wake up in the morning, and there's something wrong. So just to put things into a little bit of context, because we always talk a little bit about what sleep architecture is and what is normal sleep. Stage 3 and 4, which have now been combined with the American Academy of Sleep Medicine for stage scoring, are what people typically think of as deep sleep or slow wave sleep. REM sleep or rapid eye movement sleep. This is what people will often refer to as dream sleep. What you'll notice is that we have more and more dream sleep as the night goes on and less slow wave sleep. So slow wave sleep is predominantly in the first half of the night, and rapid eye movement sleep occurs in the second half of the night with greater intensity. This is relevant if you're thinking about REM behavior disorder, which we'll touch on briefly, because most people who act out dreams in their sleep typically do it in the early morning hours, and this is why. We often think that when we go to sleep, our brain turns off. And I just want to give you a picture representation of how in some ways this is true, and in some ways it's not. This is a PET scan image of the brain. There are 3 different images, A, B, and C. A is the brain when you're awake. The more green, red, and yellow you have, the more active the brain is. Red is most active, yellow is next, then green, and then you go into lighter shades, blue and lavender, which is less brain activity. So sleep is not completely brain turning off. The brain is just shifting to other activities. Some of those are restful and some of those are not. Physiologic role of sleep. Your heart rate should drop when you go to sleep. Your blood pressure should decrease when you go to sleep. This is a resting phase. It's a recovery phase for the body. If these don't go down, it can have ramifications in terms of your daytime waking heart rate, waking blood pressure, and your risk for heart disease and other underlying disease processes. There's a downregulation of body chemicals, which would otherwise be pro-inflammatory, meaning if you cut yourself, you get inflammation or swelling at that site, you're going to have inflammatory chemicals coming there. Stress, day-to-day activities increase the body's inflammatory response. Typically, there's a downregulation of those chemicals when you go to sleep. With obstructive sleep apnea and also possibly restless leg symptoms, although I haven't seen any data for it yet, it probably will come out in the next few years, showing that there's actually upregulation of inflammatory molecules during sleep because of sleep disturbances. How do we fall asleep? People think, especially people who have insomnia, think that they have to fall asleep and they're thinking about going to sleep. Sleep is not a conscious process. You don't think about it. It's not something you have to work your way to get through. It's something you don't think about and it will happen. But it is a process where the brain is disconnecting or reducing stimulus to certain areas by downregulating certain receptors and upregulating other receptors. So the point behind this is to say there's a lot of different chemicals made by your brain, particularly in the lower part of your brain, which either go up to the surface part, which is known as our cortex, and that includes your frontal lobe where you do all your complex thinking and your emotions, temporal, which is auditory, memory, and occipital, which is your visual. It sends messages to those parts to either say, wake up, with certain neurotransmitters, or go to sleep with other neurotransmitters. So there'll be downregulation of some and upregulation of others as part of the chemical process of how sleep occurs. This is what a lot of the sleep aids do. Sleep aids technically will either block neurotransmitters that promote wakefulness, or they will upregulate neurotransmitters that promote sleepiness. Briefly also to just talk about napping. A lot of people will say it's perfectly normal to nap. And it probably is, especially if you haven't had enough sleep the night before. But if you have problems with sleeping at night, or if you're getting 8 hours of sleep at night and you're still taking naps during the day, it's probably not normal. And what this is showing is that the more someone naps, the more likely they are to have an underlying medical disorder. So how do sleep disorders present? How do you know if you have a problem? So if someone says to me, I'm tired, I always want to be able to distinguish, are you tired because you just can't focus, you don't have energy, or is it you're actually sleepy? If you were to sit down in a boring situation, you would be out. Or I have patients who tell me, I'm not sleepy, but I can fall asleep anywhere, anytime. Okay? In their mind, they've been able to do that all their lives. If they were in a boring situation, they'd be out. So to them, they're not sleepy, but they actually are, because that's not a normal response. The converse of that is, I can't sleep. My sleep is disrupted, I'm up a lot at night, I wake up feeling tired, but I can't fall asleep or nap during the day. Even if someone were to give me a chance to nap after lunch or around 1 or 3 o'clock in the afternoon, which is our typical sleep window period, if we are vulnerable to being sleepy, it's not going to happen. A third of the Americans that in the current population, it's probably more than a third, it could actually be up to half at this point, have symptoms of insomnia. And that's often perceived as they're not getting enough sleep at night, they wake up feeling tired despite having slept all night, or they're waking up frequently at night. So it's not that they're not sleeping for 8 hours, but they may wake up 6 or 7 times at night, wake up, look around, fall asleep 5 or 10 minutes later, but they still feel tired and worn out during the day. 50% of the people who were surveyed in this particular study felt that their insomnia was serious, and 10% had actually taken medication for it. In terms of absolute numbers, they're saying that 40 million suffer from chronic insomnia. 95% are undiagnosed and untreated. 20-30 million people actually have intermittent insomnia. So it's not all the time, but maybe 2 or 3 times a month, maybe more than that or less than that, they will have trouble sleeping at night. Just to go over the definition of insomnia, there are different kinds. So transient, less than 2 weeks. I'm going to just skip the middle one because it's self-explanatory. For chronic is difficulty sleeping every night, on most nights, for at least 6 months straight. The triggers for insomnia. The most common ones are traumatic experience. Now, these may not always be recalled. So we will know people who have trouble falling asleep after a divorce, a lost relationship, loss of a loved one, job loss. That's not a small thing, especially in this current economy. But there are a lot of people who will tell me that they don't recall ever having a particular trigger or stressor occur. And what I just want to point out with that is that a lot of us, we all have a certain threshold after which we'll develop insomnia. And I'm sure everybody's experienced this. There will be some difficulty falling asleep just because there's a lot of anticipation or anxiety about that particular event. So you temporarily cross your threshold for insomnia and you have trouble sleeping that night. All of us typically go back. People who develop chronic insomnia, they are slowly working their way up to right up to their threshold, and it can be a very small event that tips them over, and they develop insomnia, but they don't have the coping skills to be able to go back below that threshold. So they will develop chronic insomnia with no clear trigger, but there actually was one. It just wasn't one that was significant enough for them to recall it 6 months, a year, or 2 years later when they're actually seeing a sleep specialist. Insomnia typically persists because you either develop bad habits, because you can't sleep, you get up, you go watch TV, you start working on the computer, you start solving your next day's problems because you're awake and you feel like there's a good way to spend your time because you're lying in bed anyway. That will cause the insomnia to persist. They may initially start out with having a stressor which caused them to wake up at night, but things persist because they start having anxiety about not being able to fall asleep, they start ruminating about how poor sleep is going to affect the next day, how it's going to affect their mood. They start stressing about, I have to go to sleep, otherwise my next day is going to be lousy. And suddenly you're not sleeping. You're thinking about the fact that you're going to have a lousy next day, that you can't sleep. You need to sleep to have a good day next day. And the whole cycle turns into a mess. But you forget about what actually triggered all of this. You just develop a habit which you're left like a little mouse running on a wheel. There are other causes other than just the poor sleep habits, and I want to touch on them briefly. Delayed sleep phase syndrome and advanced phase syndrome are based on our body clock, and I'm going to move ahead for a minute just to explain this and then come back. Circadian rhythm is our body's endogenous 24-hour cycle. It's actually a little bit longer than 24 hours. If you put someone in a dimly lit room, didn't give them any sunlight or darkness, so they had no light cues to tell them what time of day it is, and you measure their body temperature, or even your own body temperature, you will find that it cycles a little bit over 24 hours. You can see there's a transient dip, and then there's a gradual increase back up to the baseline of 37.6. Melatonin, which has received a lot of press and is ubiquitous in our society as a sleep aid, also follows a certain cycle, and that cycle follows a circadian rhythm pattern. So the same person, dimly lit room over a 24-hour period of time, you will see that gradually they'll have a rise in the melatonin. They'll have a peak. It's about 7 or 8 hours after the initial rise, and then you see a gradual decline and then a base rate again. This is also following circadian rhythm. The reason why this is relevant, what melatonin does is it tells our body to shift to dark cycle activities. In a bat, that means wake up, fly, and go get bugs. Okay? In us, it means go to bed. It's time to go to sleep. This is relevant because a lot of people think if they take melatonin, it's going to help them fall asleep, or it's going to improve the quality of their sleep. You need very little levels of melatonin to actually promote dark cycle activities. The bigger problem is most of these individuals have a very active mind and can't fall asleep, so melatonin is often not as effective as we'd like it to be. In adolescence, there's a shift in the biologic or circadian rhythm. So, as I had mentioned before, most of us by 9 or 10 o'clock, we're ready to hit the sack. We're shifting into dark cycle activities. Most teenagers are just starting to go into their dim light melatonin onset. Everything is shifted over by 5 or 6 hours. So they're starting to have a little bit of they're starting to have some increase in their melatonin level, but they don't have a strong drive to sleep. Their ideal bedtime, yes, it actually typically is between 12 and 2 o'clock. They did some studies where they changed the high school start times to 9 or 10 o'clock in the morning and actually found that there was a marked improvement in school performance, grades, and also a dramatic decrease in school truancy and misbehavior. And one of the biggest problems in our society right now is that a lot of kids have TVs in their bedrooms, their computer assignments are on the computer, they have cell phones and iPads, and they're doing all this stuff in the bedroom. And the blue light from the computer is the exact wavelength which suppresses or turns melatonin production off. So that bright light, what you're actually doing is further delaying your melatonin release. You're turning off melatonin. So it's a really big problem, and this holds true for adults too, people who have trouble sleeping. If they're working on the computer in the evening, they're getting that blue light exposure, they're less likely to be tired or want to fall asleep again, especially if there's some mind activity there to begin with. And it can have a marked impact on their sleep quality and on their bedtime. Yes?
Does TV work the same way?
On some level, yes, but TV is not giving you just blue light. I mean, if you look at the backdrop of a lot of the computer screens, they have blue light.
Right, yeah.
But TV, because of bright light, if as an adult you're not getting out, especially older patients who don't get out a lot during the day, right. That bright light from the TV could be enough to turn it off.
If you use the TV to fall asleep, which I do, I have it on,
right.
And I sleep, I'll like sleep within 5 minutes,
right.
And then I have a timer and it goes
That's
off.
Fine.
And I do that every night because if I go to bed, I'm going to be thinking.
If you're using this as a way of turning off your mind activity, which is very important, because if your mind's active, you're not falling asleep, then that's fine. You're using it as a sleep aid. It's not really acting as a stimulant for you. It's not having an impact. It's not mentally engaging you. It's not drawing you in and keeping you involved. It's not an issue.
I'm not a teenager, but my natural rhythm is to go to bed at about midnight and get up at 8 or so.
And
is there anything wrong with that?
There's nothing wrong with that. So there are some people where it's not just during adolescence. That's their biologic rhythm.
We go back a little bit to that napping thing. When I go to sleep, get up and go on with my day. I'm not a napper. If for some reason I'm tired and I do nap, I'm very cranky when I wake up. Napping is not good for me.
Got it.
My wife, on the other hand, can nap in the middle of the afternoon, and it's like siesta time.
Right.
You know, that's just different rhythms, right?
It's different rhythms, it's different biology. If she has no trouble falling asleep, if she's happy with it, it's not broke, don't fix it. But it is variability in people's biology. Siesta time is part of that circadian rhythm. If you sleep, let's say some people only need 6 hours. Let's say you need 8 hours. That's your ideal sleep time, and you get 6 hours. Then typically between 1 and 3 o'clock in the afternoon, and everybody's zone is a little bit different, you're going to hit, there's circadian rhythm has a certain lull at that time. So the circadian rhythm is not promoting you to stay awake, it's actually promoting sleep a little bit at that time. And you've been up usually for about 7 or 8 hours, most people, if they've got up at 6. Yeah, they've been up for about 7 or 8 hours at that time. there's more of a drive to sleep. So people tend to feel a little sleepy and are more vulnerable to fall asleep. They will then typically go to bed later. So they may sleep from 12 to 6 and take a 1 or 2 hour nap in the afternoon, and that's their typical pattern. That's perfectly fine. There's nothing abnormal about it. Why does insomnia matter? Primarily because insomnia is often associated with mood disorders. About 50% of people who develop insomnia within a year will go on to develop depression, and vice versa. If you have depression, even if you don't have a sleep disorder, about 50% of those people will go on to develop insomnia within a year. If you treat someone's insomnia but you don't treat their depression, the insomnia may not resolve. And if you treat someone's depression without treating their insomnia, their depression is not going to resolve. So you really need to treat both. Sleep duration, this was a composite study where they looked at a large number of people in terms of how many hours they slept and whether they had underlying heart disease and whether they were likely to die from a heart attack. The bottom line from all of this is you can see these are hours of sleep, habitual sleep duration hours, and the y-axis is the relative risk of having a heart attack. If it's a wide gray band, it means there's a good chance you're going to have a heart attack. If it's a narrow point, there's a good chance you're not. So 6 to 8 seems to be the range wherein, and this is again for most people, not all people. Some people are biologically short sleepers and they only need 5 hours, and some people really need 9 to 10 hours. That's their biologic rhythm. But the norm is 6 to 8 hours. If you're sleeping less than that, you're more likely to have a heart attack. And the odds ratio, if you get 3 hours of sleep a night, is 1.4 times more likely to have a heart attack. If you're getting 9 to 10 hours of sleep a night, you're 1.8 times more likely to have a heart attack. There is data which shows that untreated depression and untreated anxiety increased risk for having a recurrent heart attack. And both of those can cause short sleep hours or prolonged sleep hours. Also, people with untreated obstructive sleep apnea may either sleep less hours or longer hours. So often this may be a reflection of an underlying sleep problem that has not been diagnosed. You had a question?
How important is it to have a relatively long stretch of sleep rather than
Short stretches?
short, broken up sleep and napping during the day?
There are studies which suggest that if someone has more broken sleep, their sleep is not as restorative, and they don't derive the same amount of physiologic benefit from sleep because there are disrupted periods for where the heart rate and blood pressure are going down. It's not like you've got the gradual trend down. You get the gradual trend and then suddenly you're up. And then you may start it again in your next sleep period, but you're not getting a sustained period where your inflammatory molecules are going down, where your blood pressure is going down and your heart rate's going down. Okay, were there other questions?
When a person has a lot of sleep, like you say, they're 9 hours, 10, they have a higher risk of dying of a heart attack. What's bringing that about? They're getting more rest than a person that sleeps only 3 hours.
They are, but their rest may actually be disrupted, and that's why I was saying they may actually have underlying sleep apnea or another sleep disorder, which is prompting them to sleep longer because the amount of sleep they're getting is not continuous. It's being disrupted by breathing events or other things causing microarousals on a brainwave level. So it probably signifies that there's something else wrong. I'm going to just touch briefly on REM behavior disorder and restless leg symptoms, mostly because they're both relevant, but we're not going to spend a lot of time on them. REM behavior disorder is specifically a disorder where people act out dreams in their sleep. So typically when you go to sleep, there is a disconnect between your brain and your brainstem. As long as that disconnect is there, you're not acting out anything that's occurring in your cortex. Otherwise, every time your brain says move your arm, you move your arm. There's a connection or a smooth line of communication. That disconnect prevents the activities or images that are occurring in the brain during REM or dream sleep to actually get acted out while you are sleeping. Now, this disconnect does not stay in place in people who have REM behavior disorder. It can be an early sign of Parkinson's. It can be an early sign of Lewy body dementia or some of the other motor neuron disorders. It can also occur with people who are on medications for depression or mood instability, Lamictal and some of the newer antipsychotics, and then Celexa, Lexapro, Zoloft, Paxil, Effexor, all of these medications, which are very commonly used now to treat depression and anxiety, can cause this as well. I'm not saying you're going to have it, but we're seeing it more frequently because these medications are more commonly used as well. So if you're on the medication, it's probably due to the medication. If you're not on the medication, you do want to get this addressed. particularly if you're hurting your bed partner. So, I mean, there are people who turn around and pound their bed partner and say, honest, I didn't know I was doing it. And they don't. I mean, most of the time they don't. Okay. I mean, there are probably some people who subconsciously want to do this. So I'm not commenting on that. But the point I am trying to make is that this is not normal. It should be addressed because it is going to potentially harm that person. A few people have ended up in the ER where they've, gotten a bloody eye because they flew out of bed. They thought they were being attacked and hit the bureau or knocked some piece of furniture down or punched a hole in the wall. So this can be fairly dramatic, and it should not be ignored. Restless leg syndrome. This is very common. It's increasing in incidence, probably just because more people are aware of it and most people just thought this was growing pains or they've always had it and there's nothing you can do about it. But the classic definition is that someone will describe as some kind of leg discomfort. It doesn't have to be pain. It can be numbness, tingling. Some people describe it as Coca-Cola fizzing in their veins or the heebie-jeebies. It's some kind of discomfort where if they move the limb or rub the limb, they will get relief. It occurs in rest, and it occurs mostly in the evening. If it's occurring throughout the day, it may not be restless leg symptoms. It might be something else. It really has to be most severe in the evening hours right around bedtime. And if it's affecting your ability to fall asleep, it's relevant. So the rest of our talk is going to be about sleep apnea and why bother, which is what most men think. This is why women bother, and this is why their husbands have to bother.
That goes both ways.
It does go both ways. You are correct that I should have another slide. So obstructive sleep apnea is essentially narrowing or obstruction of your airway, but it can occur at multiple sites. Now I've put down 3 here, but I'm just going to go over this based on your picture. This is a cross-section of the head if I were to go down and cut myself and open. This is the nose. This is the back of the throat. Your tongue is here. This is your mouth. This is the back of your airway. This is your swallowing pipe here and your this is your swallowing pipe here and your vocal cords are over here. Obstructive sleep apnea is narrowing or complete closure of some part of this airway. And as you can see, it can occur at multiple sites. It can occur at the back of the nose if you're a nose breather. More often it occurs in the back of the throat, or the tongue can actually flip back and occlude the airway when you fall asleep on your back. It can also occur due to narrowing here, because when you fall asleep your jaw relaxes, and if this airway back here is narrow to begin with, the further narrowing of the airway from the jaw relaxing can result in closure or narrowing of the airway. So apnea, is when the airway completely closes and there's no airflow. Hypopnea is when the airway narrows. You are able to get some airflow through, but not enough. At some point, either your oxygen level drops by 4% or the brain shifts to the wake mode for 3, 5, 10 seconds, long enough so that airway can open and you can breathe comfortably, and then you fall back to sleep. Those microarousals on a brainwave level also have an impact. And so not only the 4% drop in oxygen level can have an impact in terms of body health, but the frequent microarousals also have an impact. So you're having a mini fight or flight episode with each microarousal. It's a very subtle change, but it's happening repeatedly. If this continues throughout the night, it affects your ability to maintain blood pressure control during the day as well. Because your blood pressure, if it's not dropping at night, it's going to stay elevated at night. It's also going to stay elevated during the day. If you have obstructive sleep apnea and you are genetically vulnerable, there's an increased chance that you will go on to develop diabetes if your apnea is not treated. So just having obstructive sleep apnea, the more severe it is, you're more likely to have diabetes. Most people have a very negative association of the standard treatment for sleep apnea, which is the CPAP machine. Most of the data for CPAP compliance and treatment of obstructive sleep apnea is that it improves your quality of life. People who are sleepy, who have daytime impairment because of their untreated apnea, they will use the CPAP, and they'll use it regularly once we work through whatever the kinks are, because it makes a significant difference in terms of how they function on a day-to-day level, their mood, their job performance, and their relationships with people. So let's talk about some of the other benefits of treating apnea. Now, increased weight definitely increases the incidence of obstructive sleep apnea. If you're tired, you haven't slept well, you're going to eat more to keep getting through the day. And I'm sure a lot of you have noticed this. If you're sleep deprived, you're more likely to eat just to get through the day, to have enough energy. But sleep apnea in and of itself affects your metabolism. It changes certain endocrine levels. So treating the apnea can potentially have a marked impact on weight loss and metabolism.
Is the machine the only solution
No.
for it if you get diagnosed?
No, there are multiple treatment options. It depends on the severity. So usually with severe apnea, particularly in a heavy or obese patient, I will not recommend non-CPAP interventions. I really recommend CPAP as the initial first line. Someone who's mild to moderate, depending on anatomy, if you've got a deviated septum or nasal congestion, treating or addressing that may be enough. In some patients that improves things, but it's still not enough, but they have a small airway in the back. There are procedures out called a uvulopalatopharyngoplasty or UPPP. I'm a little conservative about that because the success rate for that in the literature up to now has always been about 30%, which means 30% of people will have quote-unquote cure of apnea, but that's defined as a 50% reduction of their breathing events. So if you have 100 breathing events an hour and now you have 50, you're cured by that definition, but you still have significant apnea by mine. There are newer surgeries where they are creating muscle flaps and moving the soft tissue in the back of the throat up with the flap, so they're kind of creating a swing and then sewing that in place. That may actually have more effectiveness. I think these are procedures that are being developed, and it may take another year or two before we have enough data to say how long the effectiveness will last. I do tell my patients I wouldn't consider things right now, especially depending on the severity of the apnea you have, but it is possible that 2 or 3 years down the road there may be some surgeries out that are far more effective than what we have at this juncture. Yes.
What about age?
The incidence of obstructive sleep apnea increases as we get older. Some of the thought is that that's due to reduced nervous tone of the airway as we age, as it is in all parts of our body. But I think some of it may actually be due to the fact that men, when they're younger, have obstructive sleep apnea, don't have symptoms of sleepiness, and at some point you reach a tipping point where suddenly the sleepiness becomes apparent and you're willing to get tested and evaluated. So I don't know how much of this is just a function of age and how much of this may be that the symptoms are more apparent and the diagnosis is occurring more often with increasing age. Now I will say that usually patients get diagnosed somewhere in their 50s and 60s. If you're 70 or 80 and you have apnea and you've never been diagnosed and it's not affecting your quality of life, it's not going to kill you. I will have a different degree of aggressiveness with a 70 or 80-year-old patient in terms of whether they should get treated than I will with someone who's 40 or 50, and sometimes even 60, because their risk for developing an arrhythmia is higher. Their risk for having a fatal heart attack is going to be higher, because the data seems to show fairly consistently, if you're in your 70s or 80s, the apnea is not going to cause arrhythmias. You haven't had it up to then, you're not going to suddenly develop it now. You probably have a better genetic makeup, so your vulnerabilities are less to begin with.
What is the likelihood of a snorer having sleep apnea?
I will tell you that if you look at the spectrum, at least with men, the standard is that snoring is on the spectrum of obstructive sleep apnea. So you can have either no apnea, snoring, mild, moderate, severe. But a lot of people will look at snoring as being on that spectrum because men who snore, even if they don't have obstructive sleep apnea, often have evidence of sleep disturbance during the day. If they do psychomotor vigilant testing, where they look to see how fast someone has a reaction time to different tasks, it will be impaired in a snorer as compared to a non-snorer, especially with men.
Women.
No, actually, that data does not hold true for women. Men who have apnea, especially if the number of breathing events are more than 19 an hour, there's a higher incidence of them going on to develop a stroke, whereas women who have 19 or more events an hour, no increased incidence of having a stroke. So there is recognition that there's gender differences, and it may be due to differences in hormone or other parts, but I can't tell you why we have less issues with that. I will tell you men have less insomnia than women. Women have more sleep problems, more issues with insomnia, yet somehow they are able to have less sequela from it as far as cardiac and stroke issues go compared with men. And I don't know why, other than to say that there's something probably related with estrogen and testosterone. When you would want to think about having sleep apnea evaluated, snoring is the #1 thing, more in men than women. Women will not admit they snore. Women tend to snore more softly. So it can be a misconception. If you're extremely sleepy, it should absolutely be considered. Morning headaches with snoring, I would think about looking for apnea because that can also be a confounding factor. Impairment in memory. Obviously, if you stop breathing, that's a reason for getting evaluated. If you're having trouble sleeping and you snore, about 70% of people with insomnia who snore do have underlying breathing disorders, and treatment can be effective. And depression, which we had talked about before, because it can be an effect of sleep disruption and its impact on mood. All organs are affected because inflammation is occurring on the blood vessel level. Blood goes everywhere, so it's impacting every organ in your body. Just briefly about heart failure. This was one study, a little bit over 1,250 patients. They looked to see how many of them had a breathing disorder, and 50% of them had more than 15 breathing events an hour, just because they had heart failure. No looking for snoring, no looking for daytime sleepiness, 1,250 patients, heart failure, all comers. 55% of them had an underlying breathing disorder. So sleep apnea or underlying breathing disorders are very common in heart failure. If your heart failure is not optimally treated with medications, if you have insomnia or sleepiness despite having your heart failure treated, you want to think about getting a sleep study because there may be something else that needs to be addressed. Benefits of getting treated for your sleep apnea or underlying breathing disorder if you have heart failure. Your x-axis is the number of months, 0 to 60, so this is a 5-year period. Survival, again, is on your y-axis, 0 on the bottom, 100% survival on top. So heart failure is defined as an ejection fraction. Here they're saying 37% versus 35% versus 35%. For simplicity, I'm just going to compare these two because these two have similar dysfunction of the ventricle, although they're all fairly comparable. These people had 44 breathing events an hour and used CPAP for 3.5 hours a night. That's the green line. 40% of them were alive 5 years later. These people did not use CPAP at all. Okay? In 5 years, only 10% of them were alive. So not treating an underlying breathing disorder in someone who's got heart failure, 5-year survival is pretty grim. If you use your CPAP, and that's what the blue line is, 6 hours a night, maybe 75% were alive in 5 years. So CPAP does make a difference in terms of survival. It also makes a difference in terms of quality of life and the chance that you'll stay out of the hospital. Because if your saturation is dropping with these breathing events, it's going to trigger your heart failure to react. Severe apnea, again, 30 breathing events an hour or more. Not treated, that's red, okay? And blue is apnea that's treated. This is, again, on the x-axis, number of months, 0 to 144, so it's 12 years. Y-axis is the chance that you would have a fatal cardiac event. About 20% in 12 years who had severe apnea and didn't get it treated had a fatal cardiac event. If they got it treated, they went almost close to normal. Normal is green. They were about 3%. So almost 11–12% improvement in survival if there's underlying heart disease if you get your apnea treated.
Can you talk more about the equipment itself, the CPAP machine?
Right. What a CPAP is, it's basically a device. It's a mask that either goes over the nose or over the nose and the mouth if someone has nasal congestion or nasal obstruction that prevents them from being able to breathe through their nose alone. The premise is that you're just transmitting pressurized air through the airway into the back where your occlusion is occurring and you're stenting the airway open. So the primary purpose is just to keep the airway open. There's no oxygen involved. The machine, all it's doing is compressing air and transmitting it through. It is the gold standard still for treating obstructive sleep apnea. It's obviously my first line of recommendation, even if someone's going to go on to consider surgery or an oral appliance, because they want to know that they're going to get efficacy, meaning that they're going to feel better after they have the surgery or use the oral appliance. So just a trial on the machine helps convince them that, okay, this is worth my while to put the money or effort into doing this because it's going to improve my quality of life. Thank you.